Next candidate.
Assalamu alaikum, sir.
Salam. 6-year-old male patient presented with sudden onset of headache with reduced vision in the left eye and left ophthalmoplegia.
Okay. Um, Sir, if you can please scroll for me, I cannot request control.
Okay.
Okay. These are CT images, axial section of plain images in an adult male patient, in which I can appreciate that there is some fullness in the left side of the cavernous sinus with some soft tissue density region and adjacent bony erosions. There is also in the left temporal region there is an extra axial soft tissue heterogeneous area which is seen just adjacent to the left MCA. And I would next like to see the contrast enhanced images to assess that whether this is some infective etiology or it is some kind of mass lesion. In this sagittal images, plain study, I can appreciate that there is expansion of sella with
Okay.
internal soft tissue density lesion. The soft tissue density lesion is showing some hyperdense components as well. It is lifting the floor of the sella. I can not appreciate any hydrocephalus. The pre-pontine region and the suprasellar cistern is effaced. Pre-pontine cistern, it is not extending into that area. It can be my differentials based on these findings can be macroadenoma, lymphoma based on the patient's age. It can be
What
lymphoma.
else? Yeah,
There
yeah.
is
What else?
calcification in the
Look,
pineal region
see. Look well inside the lesion. Look
inside
well.
the lesion. So can it be bleed within the tumor
Yeah, excellent.
apoplexy?
Excellent. So, what's your differential diagnosis?
My differential diagnosis is macroadenoma with pituitary apoplexy or
Excellent.
lymphoma.
Okay. What will you do next?
I will next do MRI, contrast enhanced MRI with pituitary protocol and orbital protocol to see the extent of the lesion and involvement of the vessels, etc. to delineate whether it is having some supracellular component. This is the MR images pituitary protocol T1 non-contrast enhanced sequence in which there is hyperintensity in the posterior part of the pituitary lesion. A lesion
Yes.
is completing the sphenoid sinus, but so it is basically macroadenoma. Looks like macroadenoma with bleed.
What is your
The
next step?
My next step is to see the vascular association, whether it is involving encasing, how much is the fat grains preserved with the internal carotids on both sides, and
Okay. What else?
what else, sir?
What is the most dangerous complication of this apoplexy?
Uh, it can cause bleed and lead to, sir, there is Sheehan syndrome, but that is usually in
No,
females,
no, no,
most
no,
of
no, no,
the
no, no,
females.
no. See. There are. This is two different entity. Sheehan
Mm,
syndrome caused by postpartum bleeding.
mm,
But here, apoplexy caused by intrapituitary macroadenoma bleeding.
mm.
Two completely different entity. So, remember, do you remember the history? The patient
Yes.
has acute sudden onset of ophthalmoplegia and disturbance of the vision. So, this is very dangerous. Okay?
Okay.
The most critical here is to protect the optic nerve. So, what is your next step?
To urgently refer the patient to neurosurgery department for decompression.
Okay. Thank you, doctor, so much. Take care, my friends, from hyperdensity inside this lesion here. Doctor, you didn't ask for sagittal, but I give you because I am very kind examiner. Okay?
Hmm.
If you didn't ask, he will not give you. The key and the secret of this case to detect this hyperdensity inside. This is pituitary macroadenoma apoplexy. Please, my colleague, please differentiate between apoplexy and Sheehan syndrome. The two different pathways, completely different. Thank you,
Mm.
doctor, so much. Next
Thank
candidate.
you.
Hi, Dr. Rami. Hi.
Welcome, doctor. Request control, please.
Yeah. Request to control.
Female patient presented with abdominal pain.
Okay, I'm just taking a moment to scroll through these portal venous phase images of the abdomen and pelvis
Yes.
in a female patient who's presented with abdominal pain. I'm just scrolling from top to bottom. Okay. Okay, so I'm just going to start with mentioning my findings in this case. Okay. And this patient's just got abdominal pain. Nothing else. Fine. So I can see that there is a focal area of a lesion in the right lobe of the liver, posterior aspect, which has got peripheral enhancement and central low attenuation. I did notice that this patient had bilateral breast implants.
Okay.
I'm concerned with this focal lesion seen in the liver, which could possibly represent a metastatic deposit. I can see a few other
Excellent.
focal areas here,
Excellent.
which are enhancing with
Okay.
focal low attenuation center. So I think these are
Mhm.
possibly necrotic mets from a prior malignancy. And because
Excellent.
she has had breast cancer, I believe that she's probably had breast metastasis to the liver.
Brilliant. Mm.
And there is a necrotic core here seen in the left lobe of the liver, which could also represent a large metastasis or some necrotic change. That's my primary differential in this case. I'm just looking at the rest of the vasculature to see if there's any tumor thrombus within any of the vessels. The portal vein is fine. The spleen, renal is okay. The gallbladder is also okay. The spleen appears okay. Maybe some calcification of the at the hilum of the spleen, possibly some calcified vessels. The pancreas appears normal. Okay, and I'm just going down. In routine practice, I would also like to assess the bones in bone window to see for any sclerotic metastasis from breast cancer. And I would like to also have a formal workup and discussion with the oncology team to see if this patient has known previous
Excellent.
malignancy.
What's your differential diagnosis?
In this case, I believe that this is likely to be a breast cancer, which is a malignancy metastasis from primary breast cancer. Other differentials that
Use the
can
mouse.
metastasize to the
Use the
liver.
mouse 1 second. Okay. 1 second. What happened for the surface of the left lobe here?
It's quite irregular, and there is some what we say is retraction of the
Okay.
liver capsule, and this is also seen in some cases of cholangiocarcinoma.
How to differentiate?
Um, Usually, I've seen this appearance, how to differentiate between cholangiocarcinoma and liver cancer, hepatocellular carcinoma.
Yeah.
Mm,
Mhm.
Okay. Normally, with hepatocellular carcinoma, there would be a scalloping, corticoregulatory, and cirrhosis. With the gallbladder itself, if there was the gallbladder, I'm not sure if the distal end of the fundus of the gallbladder, that seems normal. If there was a gallbladder cancer, then you would be able to see other features such as retraction of the liver, and I wouldn't. I think possibly other areas of metastatic deposits elsewhere, but I'm not sure. Actually.
Doctor, one sequence, we ask for one sequence to differentiate between cholangiocarcinoma or other. Which sequence?
You can do arterial imaging and
No.
then no.
No.
Okay.
What else?
Would you do MRI?
Delayed contrast.
Delayed phases. Okay.
Why?
Washout of arterial phase in hepatocellular carcinoma and
Yes.
prolonged enhancement in the cholangiocarcinoma.
Excellent, doctor. Thank you so much.
Sorry.
A very nice case. Doctor, you are brilliant. Today, amazing.
Yeah. No, gynae, very bad. My cervical cancers and things, very, very bad. I haven't done much gynae, which I hope is not good, but yeah.
Hopefully,
okay.
you will not present it with guy.
Yeah. Okay.
Really, Viva need some luck. Really, I'm not joking. So all of you pray too much to get some luck. Anyway, leave the mouse, please. What happened here? You did very well. He start from the beginning and he pick up this asymmetry between both breasts. There are a asymmetry. There are left mastectomy. This is very important. My colleagues in all chest X-rays, especially chest and CT, first comment for you should be on the breast. You can see or not there are mastectomy or not in female patient. Second, he search the liver and he find this and this. Okay, and he correlates the finding with each other. What happened here? Multiple left loop lesions associated with retraction. In case of breast cancer, this is very common. Metastatic breast cancer. Dr. Anthony, why metastatic breast cancer cause this pseudocirrhosis type? Why?
I think when you treat breast cancer metastasis, will it cause the involvement of the liver to be retracted?
Yes, excellent. Treated breast cancer may cause this pseudocirrhosis pattern, and after complete treatment or curation, the liver regain its normal surface. Okay, a differential diagnosis of a cholangiocarcinoma versus treated metastatic breast metastasis was made. How to differentiate? Ask for delayed phase. In delayed phase, cholangiocarcinoma will show contrast uptake because cholangiocarcinoma is hypoenhancing. Didn't show enhancement in the arterial and very weak in the venous, but show well a considerable amount of enhancement during the delayed phase. And this is a differential point. Okay, thank you so much.
Thank you.
Doctor, can I ask a question, please, about the case?
Yes.
So what was the diagnosis? Is it a breast metastasis
Yes.
or cholangiocarcinoma? Because, and the second question, what's the how can we differentiate between both? Because both will take maybe delayed enhancement.
No. Both will not
in cholangiocarcinoma and in metastasis may take the delayed enhancement, and the capsular retraction is with the cholangiocarcinoma.
See, this is the case. No. Thank you for your question. First of all, to differentiate, number one, you must ask the history, or our doctor pick up this left mastectomy, and this is very important. Second, radiologically, from radiological point of view, cholangiocarcinoma didn't show any uptake in the arterial phase. And if you remember the case, I'm trying to open it, but the internet is not good today. If you remember the case, see, this is a venous phase. Do you think, our doctor, cholangiocarcinoma will show this enhancement in the venous?
These are METs. So all of this wide
yeah.
area will be METs from the breast cancer rather than cholangiocarcinoma.
Sure.
Okay.
Next, another point, cholangiocarcinoma is almost associated with dilated biliary radicals. Would you detect any dilated biliary radical here?
No.
No. Third, if you do any delayed, you will find the opposite. This hyper enhancing area in the according to breast mets, if you do delayed, this hyper enhancing area will show washout, considerable washout. But in cholangiocarcinoma, you will see enhancement in the delayed, completely two opposite pathways. Okay, doctor, is it clear for you?
Okay, doctor. Thank you.
Next candidate.
Sorry, doctor, there is a bilateral mastectomy or left side only?
I think it was left-sided because the right side looks like previous augmentation. Okay.
It is bilateral breast implant.
Yeah,
I think bilateral.
Again, let's check. It is bilateral implant, but if you concentrate, you will not find any breast tissue in the left side. Okay? This clear, doctor?
Yeah.
This is the point. And the most important one, this is asymmetrical. See, doctor? See here? What do you think? They remove this breast or this breast?
So they remove the left one and the augmentation on the right side.
Yes, yes. See, also we didn't have the actual history, but from radiological point of view, I can't detect any breast tissue here. But here, see, there are skin, subcutaneous, and there are parenchyma here. So, and another point, the silicone here is larger than here. This means the volume removal, here there are volume loss. Finally, if you look, the both breasts from the outer side, from apparently equal in size. Okay, so
the
I
implant,
think
on the right side for augmentation, on the left side for mastectomy and the second to tumor.
yes. See. Finally, we didn't have the actual history. What we are doing, we are seeing some radiological signs, and we are trying to interpret it. Okay. That is all.
Okay, thank you.
Okay, thank you, doctor. Next candidate.
Yes, hi, doctor.
Welcome.
Yes, I'm presented with a scanogram for an infant patient, which I can see there is a right soft tissue opacity pushing the power lobes.
Doctor, why you didn't ask me about the history?
Oh, sorry, doctor. What is the history of the patient? I forgot.
Relax. Take a deep breath. This means that you are stressed, a little bit stressed. So relax. I will give them one advice and then you will start. Okay.
Okay.
My colleague take home advice. In radiology, especially in this hot seat during the exam, concentrate on the whole meaning. The examiner have no time, and you don't have the good time to tell everything. So concentrate on the scenario of the case that you are presenting with. What happened in the last year? First of all, thanks for all the previous question. Any question is welcome. It enriched our session. But I must give you my experience. In the exam, concentrate in the logical scenario. What happened, Dr. Anthony? What he did? He suspect that there are some breast asymmetry. So he gave me a general word. Doctor, it looks like mastectomy due to breast malignancy. Thank you so much. Okay, why? Because the main issue is in the liver. He didn't have a full data about the patient, but he get the meaning, he get the scenario, and then he start to build his diagnosis. And finally, examiner will give him a full mark or very high mark. Why? Because he get the meaning, either it right or left. I know that the doctor who asked about which side, you are very accurate, and your question is very good question. Okay, I know you wanted to detect the technique why there are mastectomy. It was a very good question, but generally concentrate in the scenario. Which scenario should I go? If Dr. Anthony didn't detect from the beginning there are some breast asymmetry, he will tell me many unrelated differential diagnosis. To my colleagues, let's start our next case. 31-week newborn female presented with hypotonia. Go on.
Okay, this is a radiograph for chest and abdomen of a neonate, which I can see there is increasing the size of the abdomen with soft tissue opacity seen in the right upper quadrant, pushing the bowel loops to the left lower quadrant. So I'm suspecting that this might be hepatomegaly or other soft tissue lesion in the kidney, or massive hydronephrosis in the kidney. So I would like to check this and other images. The the X-ray chest appear normal. I can't see any lung abnormality. There's no pleural effusion. There is mild increase in size of the heart.
What else? Do you remember the history?
Hypotonia.
Yes. So, which part of this babygram should you concentrate on?
The mediastinum, if there's an anterior mediastinal lesion.
Okay, there are no mediastinal region. What else?
I would like to check the one for any abnormality.
Yes. Look at the pelvis, please.
Yeah, I can see there's. I can't see the sacrum. The sacrum wall.
What else?
I can't see the sacrum. And
are you sure?
I would like to check in the other if there's any other orthogonal view, but I can't see the sacrum.
No. Again. What about the sacrum? You can or you can't?
I can't see it.
Yeah, say. So what's your diagnosis? Give me a differential.
So
the sacrum is present or absent?
Absent sacrum.
At least tell the examiner there are absent sacrum. If you didn't know the name of diagnosis, doctor, absent sacrum. Okay, very good. What is your next step?
I would like to have a CT for this patient.
A CT? This is a baby.
Okay.
Ultrasound, we should use ultrasound. What happened here? L4, L3, 2, 1. What happened here? What happened for this structure?
This is teaser cord.
Teaser cord? What meaning by teaser cord? Low or high level of the cord?
Low level.
Okay. Normally, we see the cord at which level in babies?
Is the baby's L2.
Okay, so this is in L1. The cord in L1, not teaser cord.
So this is called a regression.
Okay. What will you do next?
MRI.
MRI. Okay. What happened here?
So this is the absence of the sacrum with caudal regression of the spinal cord. The conus is at the end at between T2 and L1.
Okay.
Yeah, but I can't remember the name. This is
caudal regression. No any name.
Okay.
No any name. When we see the cord below its normal level in neonate at L2. Below this, teaser cord. Above this, high level. Okay, absent, high level. The end of the cord or the conus medullaris seen at D12 L1. But here, because of absence of the sacrum, okay, this is a sacral regression syndrome. Doctor, for sacral deviation syndrome, what is your next step? What do you want to search about?
I would like to check if there is any other congenital abnormalities.
Like look here. Like what? There are very common,
cardiac
yes. What else? There are one syndrome very common associated with vertebral anomaly and the cardiac anomaly. What is the name of this syndrome?
Achondroplasia?
No, first letter of it, V.
Vectral.
Okay,
yeah.
you find the vertebral and the heart. What should you do next?
Anorectal anomalies.
Okay, we should examine the anus and rectum. What else?
Tracheoesophageal as well.
Do you think this patient may have tracheoesophageal atresia?
No, the stomach shadow is well
okay.
seen.
What else you want to rule out?
Renal anomalies.
So you will do ultrasound. Okay. Thank you, doctor, so much. Doctor, I wanted to give you advice. You have all knowledge in your brain. Okay? But keep calm. It is not an easy situation, the hot seat, by the way. It needs a lot of training. Okay? Why? All of us has a good knowledge, but to regain this knowledge according the presented case, it is not an easy. Okay? So don't worry, keep calm, look well, and listen well to the history. From the beginning, I told you he has atonia. Atonia means I will not look at the chest from the beginning. My eye in the vertebral column. I will look from here. Absence of the sacrum. Okay? You did very well when you describe this bulging. Okay? This is very good, but the pathology is here. Thank you, doctor, so much. It was a case of caudal regression. Thank you. Next candidate.
Yes, sir. Assalamualaikum.
Doctor, this patient has wrist vein.
All right. I'm presented with ultrasound of wrist, grayscale images. Here I can see that there is thickening and increased echogenicity of one
Excellent.
of the tendon of first extensor tendon of the
Okay.
compartment at the wrist.
Good.
And the vessels appears unremarkable with flow in it, and this increased thickening and echogenicity of the first tendon um, at the level of wrist would raise
Then what
it is
happened?
not vascular. There is no vascularity in it, and overlying vessels appears unremarkable.
Okay. What about this vascularity?
This
Where is
vascularity is in the retinaculum or
okay?
adjacent synovium.
Okay, excellent. So what's your diagnosis?
My differentials would include any infective or inflammatory pathology, including tendinopathy, tendinosis, along with adjacent hyperemia and
One second. One second.
thickening of
Tendino
synovium.
see, one second. Tendinosis plus surrounding hyperemia equal any another diagnosis.
Surrounding hyperemia.
Yes.
Hmm.
When the tendon is surrounding by inflammation, what is your
Yes.
diagnosis? What is the name of inflammation of the tendon and the synovial sheath?
Synovitis
Yes.
or yes, tenosynovitis.
Okay. Okay. Very good. Very good. One second. Tenosynovitis. Okay. In tenosynovitis in the first. You see, this is the first extensor. What is the name of
Yes.
the disease in the
Yes, it
tenosynovitis in
has
the
a
first?
yes, it has particular name, maybe De Quervain.
Excellent.
Sorry,
So,
tenosynovitis, yes. De
so
Quervain.
De Courvin or De Courvin, because it is a French name, De Courvin syndrome.
Okay.
Okay. Why I bring this case? Why? Because most of us are not familiar with musculoskeletal. Okay. And this is a very important. De Courvin, very common, very frequent. Okay, my colleagues, De Courvin, because it is a French
De Quervain.
pronunciation. Tenosynovitis. This is the tendon. Then there are fluid. Then this is the fluid. Then surrounded by hyperemia. So this is a tenosynovitis of the first extensor compartment. Diagnosis is De Quervain. What is your management, doctor?
I will immediately convey the findings to the referring clinician and orthopedic referral as it need rest and steroid treatment with conservative management and follow-up imaging.
Thank you, doctor, so much. Next candidate.
Thank you, doctor.
Next candidate.
Yes, I'm requesting control.
Thank you. This patient has thigh mass. Go on.
Thank you. So I'm presented with T1 sequences of the left thigh. I'm going to scroll through the sequences before conveying my findings. Okay. All right. Can I look through the rest of the sequences?
No. See, doctor, don't
Yes.
don't take any sequence before request.
Okay,
Why?
apologies.
We
I
are
apologize.
no. We are trying to simulate the vibe. In the vibe, what
Yes.
happened here? It will give you this one.
Okay.
And
Fine.
almost another one. What's your provisional diagnosis?
Okay. So I can see that there is a subcutaneous T1 isointense and heterogeneously intense lobulated lesion in the anterior and medial aspect of the thigh. This lesion does not invade the musculature, vessels, or the bones. It is in the subcutaneous region. I would like to look at the rest of the sequences, the T2 and
Doctor,
diffusion.
what is the content of this lesion?
So this looks like um, an aggressive lesion. Malignancy is my top differential. So
Why?
the reason is the size of the lesion, the heterogeneous appearance, and the fact that there is no stranding around it to suggest an inflammatory mass or an infective mass. And I would like to find out from the clinicians the
Doctor,
onset.
this is T1. What about this
Yes,
signal?
so there's a high T1 signal within the mass, and this is suggestive of hemorrhage. So this is an aggressive lesion with internal.
How to differentiate this or to confirm, is this hemorrhage or something else?
So I would look at the T2 sequence and the post-contrast.
No.
As well as the fat saturation to rule out a fat-containing lesion. So these are fat saturation sequences which demonstrate a signal drop, which excludes hemorrhage, rather it being fat.
So this is hemorrhage or something else?
So this is fat.
Okay. What is next sequence? Last sequence do you want?
Contrast in
this is contrast.
Okay, so this lesion demonstrates heterogeneous enhancement with internal areas of no enhancement. Given the fat components within this lesion, I will put a teratoma.
Again, doctor, you see fat. Look at this sequence very well, and then tell me differential diagnosis. A possible differential.
Okay.
What happened here?
So this looks like an aggressive lesion.
Yes. What happened?
It looks like it could be a rhabdomyosarcoma. It could be a liposarcoma.
Doctor, from the beginning, we find a fat and then enhanced soft tissue. And what happened here? If the examiner give you a new sequence, be sure there are a new information. What is the new information here?
Okay, so the bone marrow is heterogeneous in appearance. And I'm trying to see if there's a connection between this lesion and the bone. There's no cortical break. And no infiltration of this lesion into the bone. So I think that this could be a primary bone malignancy with metastasis to the soft tissue, or a soft tissue neoplasm with metastasis to the bone.
Which more logic, doctor? Which more logic? Number one, doctor.
I would expect it to be a.
Where is the center of the lesion? In the bone or in the soft tissue?
The soft tissue. So it's a
soft. Where is the primary?
It's the soft tissue. That's the primary. So it's a soft tissue sarcoma with metastasis.
What type of sarcoma?
Bone. It looks like a rhabdomyosarcoma or a liposarcoma.
Which of them is more logic?
I would say lipo because of the fat content. And
what is your next step?
The next step is to alert the clinical team and refer this patient to a sarcoma center where they can biopsy this lesion.
What is the most common site of liposarcoma?
liposarcoma would be
There are two common locations.
mm,
The thigh, one of them. What is the
so
next one?
thigh
Or
and
what is the
I
other
think
one?
retroperitoneum is
Excellent.
also differential.
Excellent. Thank you, doctor, so much. This is a case of liposarcoma. Why? This is T1. My colleagues, H, H, H image, H sequence. The examiner gives you. There are multiple findings in it. There are many information. Try to squeeze the image in front of you, even a static image. Okay, my colleague? The easiest one if the examiner give you a static image. Why? He give you the image of interest, the image of pathology, the image of fruit. Here, what happened? T1. Why I give here start with T1? I want from you to tell me, doctor, this is a large soft tissue mass containing high T1. Okay, I will see post fat set. Okay, what happened? Oh, doctor, it reduced or there are fat because it is nullified in fat site. So this is fat containing tumor. Doctor, show me the post contrast. What happened? Oh, large soft tissue mass. Doctor, I'm dealing with liposarcoma. Okay?
Okay.
And when I give you this one, there are metastases. There are metastases. By
Yep.
the way, this lesion, see, I will show you what happened. See, metastatic liposarcoma. Not even in this side. What happened here? See, my colleagues, there are multiple skin metastases
Mm-hmm.
here and here and here. There are a vertebral. Okay, see what?
Yep.
Vertebral and the perivertebral and the hepatic. Okay, see, it was a metastatic liposarcoma. See, my colleagues, even the
Mm-hmm.
vertebrae, there are multiple deposits. Thank you, doctor, so much.
Thank you.
Next candidate.
Hello, sir. Can you hear me?
Yes. Request to control these. Would you request to control?
Yeah, I've gone under view, but I can't see where to request control.
Okay, this patient has trauma.
Sorry, I didn't hear the history.
Patient presented post-trauma.
Okay. This is axial abdominal CT arterial phase series. I'll just take a minute to check through the findings and then report back my findings. Okay, if you scroll back to the level of the kidneys, please. The most obvious finding here is that there is a retroperitoneal hematoma centered around the right kidney. It is seen to displace the kidney anterolaterally.
Yes.
Can you please scroll a bit higher, please? Just trying to check the integrity of the right renal artery. It appears to still, even though kind of compressed by the hematoma, it is still intact. However, there is a blush of contrast within this hematoma. I'm still not yet able to trace where it's coming from.
What's your differential diagnosis? What's the diagnosis, doctor?
So this is a case of retro, and I think there's a bit of intraperitoneal hemorrhage too. I'm thinking it's due to renal laceration, but then can I check the coronals, please?
No coronal, doctor. This is the only available.
Okay.
What's your next step?
So I can see some what looks like leakage from the IVC, and it's also showing abnormal contour as you go down. So I'm thinking it's a case of IVC laceration.
Okay, what is your next step?
There are also hypodense areas within the liver suggestive of liver laceration as well. I will urgently convey my findings to the referring physician, as this patient may need some form of intervention, urgent intervention.
Okay. Thank you, doctor, so much. But is this patient shocked or not? Hello?
Yes, I'm just looking at the bowels. If I consider the IVC, I would say the patient is in shock.
Okay, thank you, doctor. This patient may be shocked because we don't know this collapse of IVC is due to compression from the hematoma or due to hypovolemia. And in my opinion, better to tell the examiner it was he almost shocked because see, very huge perirenal hematoma. Thank you, doctor, so much. You did very well. This is a case of trauma, and there are a huge perirenal retroperitoneal hematoma due to injury of one of the vessels. Look, my friends, look at the right renal artery, and you must tell the examiner a laceration of the right renal artery. Look here, there are blushing of contrast. Go down, this blushing, down, 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 down. All this is blushing. This is life-saving case. Okay, my colleagues. There are liver laceration. At the end, you should tell the examiner, first, I will resuscitate the patient. Second, I will wait for delayed phase. Why, doctor? Why we should wait for delayed phase?
There may be other sites of vascular injury that's only apparent.
No. Delayed excretory phase. Why? To rule out injury of pelvic calyceal system. Okay, my doctor. It's very important to tell we want to assess the pelvic calyceal system, so I will wait to excretory and delayed phase. Thank you so much. Next candidate. Next candidate. Hello. Any candidate available? Okay, Dr. Ali, did we finish our list today?
Sir, I think one of the candidates was not available, candidate 15. So 16th was the last one who gave Viva today.
Okay, thank you.
Sir, I can take it if you want me to.
Okay, did you take a chance or not?
Yes, sir, I did.
You did? You take a chance?
Yes, sir.
Okay, but I wanted to ask, what is Dr. Ali, our organizer today? He is online or he left? Dr. Ali, he is not here. Dr. Nagam, not here also. Okay. Doctor, give me 1 second. Anyone who didn't take a chance wanted to participate now? Anyone wanted to participate, my colleagues?
Yes, I do, please.
Dr. Nagam, did you take a chance or not?
No, I was so busy today. I just found few minutes. If any case for me, please.
Okay. After Dr. Nagam, the previous doctor who request another participation, I will give you a case. Okay, doctors? Priority for those who didn't share at all. Dr. Nagam, welcome. 70-year-old male patient presented with dysuria. Hello?
Yes.
Yeah, go on. 70-year-old male patient presented with dysuria.
With H?
Dysuria. Difficulty urinating.
Okay, tamam. So I'm presented with MRI of the pelvis of 70 years old male who presented with dysuria. The most striking abnormality is heterogeneous appearance of the bone marrow in the pelvis and the femoral heads. The prostate appears enlarged and heterogeneous with multiple areas of increased signal intensity. I'm looking for signs of aggressiveness, like invasion of nearby structures or enlarged lymph nodes, which I cannot see. The rectum is unremarkable with preserved.
Look again to the prostate. What happened?
Okay, heterogeneous with areas of high and low signal intensities, mildly enlarged.
Which of them is abnormal, the high or the low?
I think the high.
No.
Okay.
Normally, prostate, especially peripheral area, this is the normal. This is the normal in T2, okay? What happened here?
Okay, there is low signal intensity on the peripheral zone of the right side of the prostate with soft tissue. Yes, with soft tissue extension into the nearby structures involving the mesorectal fat and fascia.
Okay, and what is this
vesicles,
structure? Yes.
seminal vesicles, yes.
Give me a
looking for the
diagnosis.
This is prostate neoplasm, prostate cancer.
Yes, with which stage?
Stage 4.
Okay, what is your next step?
Okay, so the patient, I would like to do ultrasound to check for the kidneys, to look for any signs of obstruction, to look for the
what else?
Okay, a biopsy, MDT meeting discussion,
bone
scan.
Before
bone scan.
One sec. Before biopsy, the patient is still in radiology department. If we wanted to arrange something for him.
Okay, complete staging, CT chest, abdomen, pelvis, PSA.
Okay, but there are something specific now for prostate cancer.
Prostate cancer.
Yeah. For something in PET scan. What is the specific tracer if I request PET scan for this patient?
PET scan. We usually do the PSA. I mean the FDG.
Okay.
So I'm not sure, honestly.
Okay. See. Thank you, doctor. You pick up the finding. Very important in prostate. We ask for bone scan. Very critical. But now, very recently, they create a new tracer specific for prostate cancer called gallium plasma. PET, you will order a PET CT, a gallium plasma, not the 16 deoxyglucose, fluoroglucose, FDG, okay? But plasma, prostatic specific antigen, okay? So this is a bone scan, static bone scan, okay? But this patient, see my colleagues again, I am trying to bring the cases that we are not familiar with. This is not pelvis, this is a prostate. Why? The field is zoomed, too much zoom. Second point, look here, this is the normal, this is the abnormal. Large prostate cancer with extracapsular extension infiltrating the bladder and seminal vesicle. Okay, so stage 4. What's your next step? Number 1, bone scan or PET scan, PET CT, but which type? Gallium plasma. Thank you so much, doctor.
Thank you.
Thank you. Doctor, the previous doctor who requested another chance.
Assalamu alaikum,
sir. Doctor, this patient presented with headache.
These are taken with FLAIR images, MR, in the patient with headache. In this, I can appreciate that there is right temporal and there's thickening of the right temporal lobe, and there is an, I can appreciate there is an extra axial soft tissue swelling as well noted adjacent to it.
Excellent.
There is some heterogeneous, no, the bone adjacent to it is normal. It is not causing any destruction of the bone. There is no heterogeneous signal seen within the sphenoid sinus. However, the cavernous sinus is showing some fullness. I would like to next see any T2 weighted images or any sagittal images, coronal, any other to delineate this area more clearly, because
This is post
this
contrast.
even fat set post contrast enhanced, in which there is an enhancing lesion which is extraaxial in location, located in the right temporal lobe. Lesion has loss of interface with the internal carotid artery. It is also involving, or there are loss of adherence with the adjacent brain tissue. However, the brain parenchyma is not showing altered signals. Mm, I am, sir, can I know the age of the patient?
See, the lesion is intracranial, correct? Putting
Uh,
the right ICA. Then go down, down, down. Where the lesion now? What is the
Sir,
name of this?
it is between the medial and lateral pterygoid muscles.
Okay, in the masticatory space, no problem. So,
Investigatory.
yeah, what do you think?
Sir, I
See?
think it can be some nerve-related tumor.
Excellent.
It
Which
is
branch? Which
it is
branch?
mandibular, or it is a branch of fifth trigeminal nerve,
Brilliant. Really brilliant. Brilliant.
but might be, I think, V2. Don't know, but it is some nerve-related tumor related to
Okay.
related to
What
its
else?
segment.
Look,
What
look
else?
well here. What else? What happened?
So there is a tortuosity of the optic nerves bilaterally,
Okay.
and there is sir, I'm trying to look for in the anterior to basilar artery. There is a soft.
What
There is
happened here? What happened
mm,
here?
sir. This is cystic. The Sir, I've forgotten the name. This is the
What
cystic.
happened here for the cella?
Mm, sir, it is hyper intense. It is hyper intense and swollen with the posterior displacement of its posterior part. Is it some cystic
See.
schwannoma?
What happened here for the cella? What
The
is the name
cell,
of this condition?
sir, I
Cella
forgot.
filled with CSF and associated with tortuous dilated perioptic CSF. What is the name of
Intra,
this disease?
intracranial hypertension.
Yes, you doctor,
Intracranial.
you pick up the most difficult pathology here, and the easier one you confuse. Why? Okay, thank you,
Sir,
doctor, so much.
I was making the correlation. Sorry.
No problem. This is a case scenario of double pathology, my colleague. See here, there are bilateral perioptic dilatation and emeticel and Gasserian ganglions. Sorry, this Michaelis cave is very dilated with this. If so, this is IIH, idiopathic intracranial hypertension. Okay. Plus that there are a nerve sheath tumor here or schwannoma. Why? Look here. The nerve, the tumor or the schwannoma started from abutting the site of the cavernous site, abutting the ICA. Then go down, take the same course of the right mandibular branch of the trigeminal. Okay, and then go down to the masticatory space. So it was a case of a right mandibular schwannoma associated with intracranial hypertension. Thank you so much, my colleague, for
Thank you so much,
today's
sir.
session. Thank you for attendance. Let's meet tomorrow.